On September 8, 1854, the handle came off the Broad Street water pump in London. It happened one day after the physician John Snow spoke to the parish board about a deadly cholera outbreak. This is usually where the story ties itself into a neat little knot. Bad pump, clever doctor, handle removed, outbreak over. Snow's own figures won't let us tell it that way. His table recorded 143 attacks on September 1st. On the day the handle came off, it recorded 12. Snow wrote that the attacks had already diminished before people stopped using the well. He couldn't say how much immediate difference removing the handle had made. That doesn't make his investigation smaller. It makes it better. Snow worked through death records, addresses, household questions about drinking water, and nearby exceptions that did not fit the obvious pattern. The famous map was one part of an argument he was already building, not a flash of inspiration delivered by dots on a page. So keep the pump handle by the fire. Just set Snow's table beside it. The table points us toward a more interesting history, not a parade of heroes who single-handedly stopped disease, but a long struggle to see an outbreak clearly enough to act. For the Black Death, even the identity of the killer comes to us through evidence assembled centuries later. Researchers reconstructed the genome of the plague bacterium from victims buried in London and securely dated to 1348 through 1350. Their work ties those sampled victims to Yersinia pestis. The human count is harder. A commonly cited estimate puts the loss in Europe between 1347 and 1351 at roughly 30 to 50% of the population. Estimate matters here. The surviving evidence is fragmentary, and the damage varied sharply from one European region to another. There is no honest way to turn that range into an exact worldwide total. What people did afterward is easier to catch in the record. In England, the 1351 Statute of Labourers responded to a restricted labour market after plague. It set maximum wages and restricted workers' movement. The law required employment and discouraged employers from poaching one another's servants. Disease had become a labour policy problem. It also became a problem of movement between cities. In 1377, the Great Council of Ragusa ordered visitors from plague-stricken places to spend 30 days separated from the city. In later decades, the practice spread elsewhere, and the period grew from 30 days to 40. That later number gave quarantine its familiar shape, but Ragusa's first rule was 30. These records do not describe one uniform European experience. They show particular governments writing epidemic response into rules for work and travel, including timed separation. The rules could not make the disease visible. They do reveal how deeply an epidemic could reach into ordinary civic life. Britain had already tried to build a public health framework before Snow went to the parish board. The Public Health Act of 1848 created a central board of health and a route for local drainage and water projects, along with refuse removal and paving. Its powers were limited. The board had no central money and could not force general action. It was a framework with a short reach. Snow's cholera inquiry worked at street and household scale. He matched deaths to places. He asked where people actually got their water. He checked the awkward exceptions, including workers near the outbreak who drank from other sources. Each piece mattered because the map alone could show proximity, but not what anyone had swallowed. Then came a larger comparison. In districts supplied only by Southwark and Vauxhall, the CDC's historical table reports 5.0 cholera deaths per 1,000 people. In districts supplied only by Lambeth, it reports 0.9 per 1,000. The gap supported Snow's contaminated water argument. The comparison still left room for other differences between the populations, and the CDC says so. On September 7th, Snow brought his evidence to the parish board. The handle was removed the next day, yet his own attack curve was already falling. One administrative act did not flip an epidemic from on to off. The less polished version is the useful one. A limited public authority existed. A physician assembled records and comparisons, then followed questions and exceptions. Officials acted on the case he presented, while the timing kept the result uncertain. Public health was becoming a way to connect evidence with collective decisions, and the connection was anything but automatic. The 1918 influenza pandemic pushed that problem across the world. The CDC estimates at least 50 million deaths worldwide and about 675,000 in the United States. Those are estimates, not a final ledger with every name restored. There was no influenza vaccine. There were also no antibiotics to treat secondary bacterial infections that could follow influenza. Without those tools, communities relied on public health measures, and they did not apply them evenly. In the CDC's reconstruction of the United States, influenza activity appeared in spring 1918, reached a far more lethal peak that fall, and returned in another wave during the winter and spring of 1919. That sequence is US-centered. The timing and force of the pandemic were not identical everywhere. Later historical comparisons found an association in US cities. Places that began combined measures earlier and kept them longer tended to have lower peak and total death rates. Associated is the careful word. These were retrospective comparisons of cities. They were not randomized trials, and several measures were bundled together. The reporting machinery kept developing. In April 1926, the League of Nations Health Office first published the weekly epidemiological record from disease reports sent by telegraph. WHO inherited that publication in 1948. It tracked notifiable diseases broadly. It was never only an influenza bulletin. 4 years later, in 1952, the same organization founded what became its global influenza surveillance and response system. 25 countries then had designated influenza centers reporting laboratory and epidemiological data. It would be too tidy to say the catastrophe of 1918 created that network by itself. The durable change was a wider habit of watching together. Smallpox offers the clearest ending in this story, and even here the ending belonged to a system. The global campaign paired vaccination with case surveillance. Teams contained hotspots, focused prevention on contacts, and managed the hard logistics of fieldwork. The vaccine mattered, so did finding the next case in time. The intensified eradication program began in 1967 with renewed political commitment. It depended on hundreds of thousands of local surveillance officers and health workers. Their work linked local surveillance with vaccination and containment. Field logistics carried the campaign from one place to the next. On May 8, 1980, the 33rd World Health Assembly adopted a resolution declaring smallpox eradicated worldwide. That is the declaration date. It is not the date of the last naturally occurring case, and it should not erase the workers who made the declaration possible. The vaccine became eradication through surveillance and organized follow-through, one case at a time. COVID-19 gives us 3 World Health Organization milestones that are easy to blur together. The organization declared a public health emergency of international concern on January 30, 2020. On March 11, it characterized the outbreak as a pandemic. Those were distinct decisions. On May 5, 2023, the organization accepted that COVID-19 no longer met the definition of that international emergency. It also stressed that the disease was still established and ongoing. The threat remained global. The emergency classification ended. The disease did not. Counting the loss required more than confirmed death certificates. The World Health Organization defines excess mortality as deaths observed above the number expected under ordinary conditions. That measure includes deaths caused directly by COVID-19 and indirect losses produced through disrupted health systems and society. For 2020 and 2021, it estimated about 14.9 million excess deaths associated with the pandemic, with a modeled range from 13.3 to 16.6 million. Visibility did not guarantee fairness. In a speech on October 30, 2021, the World Health Organization's Director General described the moment the world passed 7 billion administered vaccine doses. Low-income countries had received 0.4% of them, while more than 80% had gone to G20 countries. That is a dated snapshot, not a description of vaccine distribution today. It shows what the totals could conceal. Across these epidemics, records and comparisons changed what people could see. Shared reporting and surveillance widened that view, but information became protection only when institutions could turn knowledge into collective action. The result depended on whether an institution could act and on who actually received the benefit. And that brings us back to Broad Street. The pump handle is easy to remember because it gives the story a hero and an ending. The table beside it leaves us with a harder idea. Seeing an epidemic and stopping one are not the same task. Keep the handle, certainly, but keep the table beside it.